So I'm happy and pleased to introduce this year's 2014 Society of General Internal Medicine Annual Meeting Awards speaker, Dr. America Bracho. Dr. Bracho is the director and founder of Latino Health Access, a center for health promotion and disease prevention located in Santa Ana, California. Dr. Bracho worked as a physician in her native Venezuela for several years, after which she came to the United States and obtained her master's degree in public health at the University of Michigan. She founded Latino Health Access in 1993 to facilitate mechanisms of empowerment for the Latino community and uses participatory approaches to community health education, including community health workers as leaders of wellness and change. She serves on the Institute of Medicine Roundtable for Health Disparities, the Advisory Committee for the Robert Wood Johnson Foundation, and the Kellogg Foundation Task Force on Health Disparities. She has received several awards for her contributions, including the California Leadership Award, the James Irving Foundation Award, and Visionary of the Year Award, just to name a few. Dr. Bracho truly embodies this year's meeting theme, Building Bridges of Generalism, Partnering to Improve Health. Please join me in welcoming this year's awards plenary speaker, Dr. America Bracho.
Thank you. Thank you so much. Yeah, this advance is nice, great. You just try that. Yeah. Good morning. Buenos días. It is a true honor to be part of your gathering. I just became 57. My birthday was a few weeks ago. And I decided that I don't want to go to places where I don't have fun. And I really, truly don't need to come here to pay my mortgage. But I do need to come here to get the energy that you have and to honor the amazing work that you have and to learn from the things that you do, to exchange, to reflect together. I am in that process. I am in that process every day, and I try to be in that process every minute, but it's difficult. I went to medical school in Venezuela, in Universidad Central de Venezuela, and then I went to work in the rural area after the declaration of Alma Ata on primary care. And Venezuela was working with community workers, which was one of the recommendations of the Alma Ata primary care, the primary care declaration. A beautiful declaration that talks about really primary care as a system, not just primary care doctors. And in that work in rural Venezuela, which unfortunately, what I'm going to tell you about hasn't changed a lot, with a lot of poverty and a lot of disparities, I found myself as a young physician without a lot of resources, material resources, but a lot of people that had creativity and strengths. And I did a lot of my learning in that community with fishermen and people working in agriculture. It was fundamental for my life because I had just graduated from medical school. And as good as you all are in teaching, medical school, when you graduate, you have to do like a recovery treatment just to get a little bit of common sense out there. We become very problem-focused, and we know how to react, and we start thinking, this must be this, and and here's the liver. Oh, the lung is calling me. Oh, yes, no, the pancreas. But Pedro, Maria, and Luis are outside, and you forgot how to talk to them. So communities has this way of healing you. And if we can actually keep the balance between the pancreas talking to us and Pedro talking to us, then we will be fine. So I think that the community did an amazing job, and I found myself treating different diarrheas in the same kid, and different skin infections in the same ladies, and a lot of tuberculosis and malaria. And unfortunately, not only that hasn't changed, but it has been getting worse in terms of, the indicators, the health indicators. And malaria is just, the numbers are growing. In any case, I thought to myself, do I really want to do this? And I love the way we call this plenary, this whole rethinking, reflecting, challenging ourselves, challenging our assumptions. Is such an important process in our growth. And I thought, do I really want to treat diarrheas, different diarrheas in the same kids for the rest of my life? Or do I want to do something to have clean water? Do I want to do something so I can add to the opportunities of kids to have successful lives and communities to prosper? So I went into public health in Michigan and became the director of HIV programs there, which is a great story, and I'm not going to tell that story too much because I am watching my time right there. But what I want to tell you is that for this Venezuelan to enter the United States through Detroit and actually be welcomed by this amazing group of colleagues that were Black and Latinos and whites, my colleagues fighting for a healthier community, at the same time that we were serving Latinos and Blacks and whites, and to have the opportunity to have balance in my view of what the African American communities are, their struggles and their strengths, and what Latino communities are with their struggles and their strengths. And understand that we were serving and working maybe with women that didn't know how to read, but I was working alongside with Puerto Rican women that were serving them. Which means that if we have the opportunity, like our former Surgeon General Tony Novello used to say, she used to say, you put a girl through school, and she will go to medical school, and then she will become the Surgeon General. You remember that Tony Novello was Puerto Rican and was the first Puerto Rican as Surgeon General. So I decided, this was my own choice, to just move a lot into community health and have been doing this work with Latino Health Access around disparities, and I'm going to tell you a little bit about that. But the whole rethinking our assumptions. Rethinking, I remember being 13 in Venezuela, 13, and I visited a home, a very poor home in that area where I was a doctor because my family is from there. And I saw this mom that had a kid with Down syndrome tied to a tree. And I was impacted. I said, why is he tied to a tree? And I asked the mom, and she said, I don't want him to escape and be killed. Because the carretera, which is not a freeway, but those roads are very dangerous. So I think that was my first encounter with strength-based thinking, where I kept that example in my heart. And I every day think, I don't know if I am in those circumstances, if I would do the same. I don't. And somehow I remember that all the time, because as I have been growing, maturing, aging, I want to remember that I am like them. That my interaction, my transaction with communities is not from a person that is different to them that are, these other people. That this is a Latina that is talking in front of you, and it's a woman, and I have a mom and a dad that were models for me. And I have kids that grew up with good schools. My son is now in family practice in Chicago. He's doing his residency. He went to Mater Dei. He played baseball. And I work with kids that play in dumpsters. And I never forget that my kids had different opportunities. And I never forget that I am a mom. Because my heart, when it advocates, is not a doctor. And it's not in public health. When my heart advocates, it's a Latina mom. It's a mom from that community that understands that our kids deserve better. So I rethink all the time, because if we want to make this society better, if we really want to make this society better, We have to join forces. We are not enough in this room. And I don't think that it's fair to assume that we are the only ones with the knowledge and the skills to transform this planet. It's not right. And when we have the assumption that in order for you to enter into this transformation process, you need a university, when you think like that, you exclude people. And you find yourself overwhelmed saying, it's not possible, it's not possible, I don't have time. Well, you know, if you don't have time, then use the little time you have to figure out who else can join. Because this is long. This is really long. So what we have done at Latinos of Access and what I reflect every day on is, how are we multiplying leadership? How are we doing that? And can we multiply leadership with assumptions of paradigms that are oppressive? If you are the one that know everything and I don't know anything, can I join you in your leadership? No. Can community workers work with you if you don't believe that they can do something? Can moms be part of the solution if you think that they don't know what they are doing? That people deserve to be poor? There is a paradigm of exclusion and there is a paradigm of inclusion. So reflecting and rethinking is a daily thing. And I think we need to stay there and challenge our assumptions, because this dominant discourse that we grew up with is pretty strong and is our default. Under stress, under situations of lack of funding, we actually go back to that default. We have money, we are working with the community, now we don't have money, we stop working in the community. Because now we have to focus on the problem. We are very strength-based if we have a grant, and then the money's gone and we are going back to the kidney. And we forget about schools and we forget about lack of parks because now I don't have money, so I have to do food labels. It doesn't work, but that's the only money I have to. Well, then be happy being mediocre, because that is not what we need to do. So just to challenge, I remember going to Detroit to talk about condoms in crack houses where people were high in crack and were not paying attention to me. So I think that the one in crack was me. You know, how could I be just talking about condoms until I recovered my common sense and said, okay, it seems like this is not the priority here. So again, rethinking as an exercise, like Dr. Bass said, have fun. Let's rethink and be humble. Why not? Who told you that that was true? You know, so when I was thinking in your invitation, and I said, well, just rethinking, why partner with communities? Why? Well, of course, because we want overall health for everybody, you know, like Miss Universe in Venezuela wants world peace. You know, yes, we want that. Good. You are so good. So, of course, we want to partner with communities because we understand that the World Health Organization says that health is not just absence of disease. It's also physical, it's mental, and it's social. That's health. So what are you doing? Kidneys. Well, we need to rethink. We need to rethink because before universities work, you know who created universities and hospitals? We did. We actually existed before hospitals. When the world started, we didn't have hospitals. True. We didn't have universities. We created them. And now universities forgot that we created them and we can recreate them. So we need to work with communities. We want people to use our services and select our universities. We want people to support our practice. We want to advance knowledge. We want to partner in research, a research that is different, that can really inform knowledge and make our communities better. Of course, we want research and publications, and we want solutions, and we want to reduce health disparities and bring money to our universities and get tenure and support that career. But we have to think in the place, in that community. Rethinking communities is also rethinking the place, the geographic place in which our communities, families, mom, dads, kids live. And we know that a great way of explaining social determinants is by saying that the place where we live, the place where we play, the place where we learn, the place where we work has everything to do with health. We know that. So if that place is really influencing health outcomes, we should pay attention. Because we need to recognize that we are one element in the huge influence of elements over that community. One. But what about that place? So the World Health Organization has a framework of healthy cities. It's also the America's Promise framework, or the Promise Neighborhood framework. It's just a framework that is more comprehensive, in which we understand that we need a place, and we need data, and we need to collaborate, and we need community engagement. And if we don't have those elements, we are not going to have healthy communities. We are not. We are not going to have healthy communities because we have hospitals or we have universities. And the proof is that there are a lot of poverty and poor neighborhoods around your own universities and hospitals. And maybe things are improving, but there are a lot of things that need to happen. So I just want to share with you the example of Oakland and the study that was made by led by Dr. Tony Aiton, that later informed the video that maybe you saw that is called Unnatural Causes. So in Alameda, if you are born in West Oakland and you are an African American, you can be expected to die almost 15 years earlier. Dr. Aiton likes to say that in order to predict your health and life expectancy, your zip code is a better indicator. It's better than your genetic code. In California, in Orange County, what we did was to select our zip codes in 1996 and choose one that had neighborhoods that were those places where the schools are mediocre, there is not safety, and try to focus on that to make an impact. We work all over the county with many programs on disease management, but we actually focus on one of the poorest zip codes to do part of our work on healthy cities. And I just want you to see this, which you know. But as we see this, I want you to think, well, I'm doing this already. Maybe I can add whatever. I'm not doing that. That should be done, or that should be done with people from the community so they are part of the awareness. So here is Orange County, and here is where we have the concentrations of Latino youth. Now 50% of the youth in the county. And here is where poverty among children gets concentrated. This is where poverty among adults gets concentrated. This is where adults with no high school are concentrated. This is where injury is very high. This is also where avoidable emergency department visits are concentrated. And this is where life expectancy is lower. So not need to go back and show you the rest. You can read all of this. But this, actually the whole production of the maps was a great project because Orange County used to report without naming the cities. It was just a blur there, you know. The dark part. The dark part is where you have injury. And I say, I don't do anything with that. I cannot just talk to my mayor and say, you see, you are there in that dark part. I need the name of the city. I need data that I can use to advocate, and you will relate to that. Without data, it's very hard to advocate. So who is going to produce that data? The mom that right now has to just leave that house because she's a victim of domestic violence? Is she going to produce this data today? She could, and she will, but today we need that data. Who can help with that? The park availability. Santa Ana has less open space than New York. You know, less than 0.5 acres per 1,000 people. So obesity overlaps right there with the lack of open space. You know about diabetes disparities. you know that the disparities has been growing, and the epidemic, the numbers of people with diabetes are increasing, but the disparities are also increasing. We know about prediabetes. 79 million people in this country, 35% of adults aged 20 years and older have prediabetes. This has been called a tsunami. This is one of the concerns of this new enrollment with Affordable Care Act. How many people with prediabetes are entering the system? It has financial implications, but really, what are we going to do? And what are we going to do with the people that don't know they have prediabetes? And as you see what we could do to help them not develop diabetes, the advices are weight loss, regular physical activity. Regular physical activity where? When? How? Again, and when you are presented with this, then we could have the risk of going back into our default. I'd rather concentrate in something that doesn't have to deal with systems. But we have to. We don't have a choice. This is not going to be solved with a vaccine. So we see that. And I'm going to invite you a little bit to our place, to Santa Ana and this very, very specific place with apartments, where people live 2-3 families in one apartment, with an entire family in a bedroom apartment, where kids are not allowed to play, where the community doesn't feel safe to go out and walk. And they tell us, you always tell us to walk to manage our diabetes, but have you ever walked in my neighborhood? And it's important to know that. You tell us not to eat tortillas, but that's the only thing we have to eat. So, we need to actually go into those neighborhoods and understand this. So our advice makes sense, but also we can develop other activities. And I took this picture many years ago in one of those neighborhoods, and I always keep this picture in my presentations, because Paulo Freire, who is a person that has informed a lot of my values in my own practice as a public health person, says that awareness increases in the presence of contradiction. You have to see the contradiction. We have to feel the contradiction, or we forget. So I want to see that, because my kids had parks. I want to see that every day. So I remember. I need to remember. I need to remember what is the face of pedestrian injury. I need to see this. I need to see this and then read again what the CDC is saying about prediabetes. And see a community that is bombarded with a marketing that makes them sick, and a community that is designed to be sick. So the Institute of Medicine, which I respect, and they are really producing incredible reports to inform this, they say it. I mean, it's pretty unreasonable to expect people to change within that design. So we need to rethink. And we need to rethink, well, how do we do this? How do we engage the community? And you know that the Alma Ata Declaration, if you check that, talks about the need for primary care to include community in your board as community workers. I mean, it's a full menu of areas where you can include the community. And we need to read that because, again, we need to remember how this got started. How this got started. So we say primary care, and we are primary care, and this is primary care. Well, this is primary care. And this has evolved. The Millennium Goals, and there are many things that have been added to this. They also have recognized that the weakest part of all of this is community engagement. We do data. We can even sit and talk to another department. But to engage the community, that is the most difficult part. So in Latino Health Access, we are not a clinic. We are a public health nonprofit center. And we have promotores, community workers. These are individuals that came to our organization as clients. Every person that comes to Latino Health Access is seen then as a leader that decided to influence their own life. The person came to join a class on diabetes. She came because she's a victim of domestic violence. He came because he's battling depression. So after going through our programs, they become volunteers, and then they join the staff. We have 42 promotores. Our youngest adult promotor is 19. Our oldest is 76. Our youngest youth promotor is 6. And our oldest is 17. And the 6-year-olds are doing outreach, telling people, my name is Pedrito. Can I have a minute? I am 7, and I came to tell you that you see this apple and you see this pizza? Apples are better for us. Thank you so much. So we go and we do outreach. And we do outreach because we owe it to the community. We need to find them, find them, find them. Why should they come to us? Why? Oh, those Latinos don't come to us and we have these great projects and they don't come. Well, why should we go? Is there something special about you that we need to go? You want us? Find us. Like Coca-Cola does, and Wendy does, and Burger King does. They find us. So we need to find them. And we go, and we try to find them everywhere. We do home visits. We run support groups in laundromats. We do diabetes management classes with great results and outcomes and clinical outcomes. And we have a healthy weight program that actually teach kids and parents how to cook. And we have a great curriculum and follow up, and we follow up in the streets if needed. We want to follow up, and if they don't come, we go. And this is Gina, one of our mom's promotoras. And again, they are paid staff, and they have health benefits. And Gina find the kids, and they are terrified of Gina. They go like this when they see Gina. And because they have the fingers, orange, because the chetos. So they go like, hi, Gina. So, and we come up with parks in these communities, but we also use our building as a community center, and women come and exercise. And these are women from our diabetes class, many of them with diabetes, many with pre-diabetes. Around 200 adults a day exercise in our own building. We identified this with the help of the parents in the community, and we were able, after 10 years, to create the first park for all of that zip code. And right now, we are developing this project of wellness corridor for all downtown, where we are partnering with businesses and hospitals and everybody there to create a space where we can walk and reclaim our lives. And here are our main policy makers for the area, from Lou Correa, who is our California senator, to Tom Daly, our assemblyman, to Loretta Sanchez, our US representative, to the mayor of our city, and city council members. 20 years. It took 20 years for them to be there working with the community. Because what? I don't know. I don't want to speculate, but you might be filming this. So what I can tell you is, for whatever reason they came, it seems like we have now a common ground. And that common ground is important. They don't have to think like me. We just have to have something in common. And this is Northgate Market. We organize the community, and we go to city council to fight for the change in the strategic plan and the general plan and health in all policies. Because without part, this is not sustainable. And we don't believe that the short term is the only thing we need to do. We need to do the long term. So this is the IOM saying that it's no longer about changing the diet and physical activity to reduce obesity. This is about policy and systems, community engagement and programs to then do this, to then do this. So as you think in research and design of programs, we need to this is actually one of the best reports I have read. The whole evaluating obesity prevention, it just is another language altogether. So we need to rethink, who are the experts? The physician? Is the physician the only expert? Or is Maria, the lady that has diabetes, an expert? An expert in her diabetes, an expert in her community, an expert in what can help her manage her condition. Who is the expert? So I think we We have several experts, but this is up to you. We are rethinking together. Do patients have a role in healthcare? Do communities have a role? So have you considered that patients could be participants in healthcare? That they are participants in their treatment, in sharing decisions, that the family needs to be involved, that you could work with community health workers, patient navigators, cultural brokers, that they can bridge your institution with the community, that they can be part of your research team, that they can be part of your board of directors, that they can be part of your advisory group. And as you think in this, think, how many community members do I have in these roles? And if you don't have any, then you need to rethink again. Because you need to ask yourself why I don't have more community members in these roles. Do I believe in this? I don't. And this is again the IOM saying that it's not just about school environments and physical and food and beverage and healthcare and the message, but there is what they are calling foundational indicators for this system that we need to track. And I love when important institutions put names to things. You know, it's like when Harvard finally spoke about love in their leadership book. And I said, well, now I can talk about love. It looks professional to talk about love because already Harvard said that. So now we can say that community engagement is important because, see, now it's a foundational indicator. So now I can write a grant and say, we are tracking foundational indicators. It is important that we understand that they are foundational indicators. That community appreciate partners, like academic institutions and hospitals, that put the well-being of our community first, not just the research project. That partners that help us identify problems and solutions, that join us with community capacity, that help us with health equity, that support advocacy, not just that come and say, America, I have $2,000. Can you organize a focus group? We need 4 focus groups and da-da-da-da-da. Fine. And you have $2,000? How many focus groups? Can I just give you 200 and you don't call me? You know, what's that? And it's not true. I will take the 2,000 many times. But you know, is there a more respectful way of engaging us? Or are we just a machine of organizing focus groups for people that are producing knowledge? So, I don't know. Community appreciate partners that help demonstrate that we add value, that community itself add value, that help us disseminate strategies, that support an agenda of creating healthy communities, that share ideas. This is the community center that we created after 10 years, Community Center and Park. And it was done with the leadership of St. Joseph Hospital. Their engineer department, the people that built their hospital, adopted this project. Their lawyers, their engineers, I mean, they put the time. I think that was awesome. We found the money to build the place, but they actually were the ones in charge of the project pro bono. This is Kaiser Permanente with farmers markets. And this is Kaiser Permanente in Coachella. We are working with promotores and Kaiser members. We actually have our research project and our IRB and the entire thing, and we are right now finishing the project and we'll analyze data on a great endeavor. I mean, the doctors are super happy, the families are super happy, and we are seeing a lot of progress. Promotores working with physicians and families in a diabetes management project. So we appreciate research. The invitation has to be done in a different way, and we need the data. And we need for you to consider that we are co-investigators, and we need to publish with you. And when you don't publish with us, you need to sit down and rethink. And when we cannot have the data that we help you get, you have to rethink. We want that data. This is a work done with Dr. Lindy Knox, who is a researcher and used to work with USC and now has her own organization. This is a path for hope that was created. It's a talking map to be used by promotores with parents as we talk about brain research and brain development. No brain research, but brain development. It was piloted with community workers, it was informed, and this is the result. So we have our own map as part of that research. And this is in Santa Ana. We did also a project with Kaiser, and we were able to demonstrate how promotoras improve adherence, how promotoras are a great partner in helping people make their appointments, get their tests, and finally reduce hemoglobin A1C. So the community prefers to be included. This is some of the strategies, the way we see strategies at Latino Health Access with our short-term and long-term and systemic change, comprehensive, with inclusion of community workers, with projects where people live, and partnerships with academia, community, business, healthcare, and the rest. So in this whole rethinking that we need to do all the time and every minute, we are challenged to rethink. We are invited to challenge our assumptions. We have to do that. Are we the only ones that have something to offer, and the community is there only to receive our wisdom? Are we engaging people with their needs? Because remember that we are trained to think in problems. So we invite people like this. It's like if I have here a person and I say, hola, you know, you are pretty short. I mean, you are not tall at all. I mean, your dress are really horrible, and your teeth are crooked, and you're pretty much old-fashioned, you know. And the way you talk is not that smart. Would you like to be my friend? Sometimes I feel we engage people like that. So I'm engaging you because you have hepatitis C. Oh, good. Thank you for engaging me. So we engage people because you might go blind, or because you are non-compliant. So let's engage the non-compliant. You don't do anything. You don't follow up. You need to come back for your appointment. Oh, sure. I'm delighted. So here is again, you know that people actually have strengths? Actually, people have diabetes. They are not diabetes. People have depression. They are not depression. They are not hepatitis C. They are not bed number 9. They are not. They actually have strength. And actually, this person with diabetes is not using insulin because he needs to use insulin in his workplace. And the last guy that did that was fired because he's perceived as a weak man. And then if he's fired, he will be without a job, and who is going to support his family? So my invitation is to this man that is caring and wants to support the family. And then we talk about insulin. So we need to think, how is our invitation? Is really engaging? Is engaging in terms of, in whose terms? So here is the paradigm. It's my strength and your need. And if this is our invitation, then it's very hard to work with communities and to include them in the way they need to be included. I think that we need to be a complete person, which means that I can be a mom, and I can be America, and I can be your friend, and I can dance in that party. Next time, invite me. I will dance. I don't have a problem dancing or laughing or questioning or not being sure. I don't have a problem. I went through that. The community already healed me. I don't need to pretend to be anything. I'm not more important because I don't move. I move and I sing and I play. And every day I'm fighting to continue in this quest for my own freedom from that system that says that this is the way you behave to be accepted, because exclusion hurts. And I don't want to buy into that. I want to just work in accepting people. I want to participate. I think we need to participate, not just preach. We need community participation. So are you voting? We need community health. Are you presenting in the school? Are you joining the board of the nonprofits? We need to participate and invite people to participate. We need to listen, we need to learn, we need to be a true partner. And this is my final slide, to just remind you who is behind the data. Who is behind these stories and these maps? Because for these kids that will become adults, hopefully without diabetes, because we are going to do a very good job together. For these kids, the word is today. And this is an urgent matter. And thank you very much for inviting me.